All right, we're waiting for a few more people to pop in, and we will start very shortly. All right, I think we should begin. Welcome everyone to our meeting. I'll begin the study meeting by introducing myself. My name is David Eisenman. I'm a professor in the David Geffen School of Medicine and the UCLA School of Public Health, where I'm also a practicing internist in the Department of Medicine. So I've been studying disasters and their physical and mental health effects for 25 years. And having worked in many communities during and after disasters, I am very aware of the suffering that occurs, the stress that continues, and the recovery and healing that takes many years. I also understand that we as researchers need to work hard to be part of that recovery and healing. So on behalf of the entire UCLA team, I want to say thank you for the honor of being allowed to conduct this study. We are really honored to have been selected to conduct this study on your behalf. Many of you here fought hard for your rights after the blowout disaster and made this study happen. It's been a long time since the disaster, and we want to acknowledge your patience in waiting for this study to begin. We also recognize that people are here today because they were personally affected by the disaster, have family and friends affected by it, and are concerned for their health and their community. This concern is exacerbated by the recent decision by the CPUC to expand the facility's capacity. We understand that many in the community want the facility to be permanently closed immediately. This emphasizes the importance of our study and its focus on the members of this community affected by the blowout disaster. So thank you for taking the time to attend. We recognize the importance of routine, reliable, accountable, and responsive communications between us and you. So this is the first of many meetings, and I will describe more about our plan for communicating with you later on. But right now, I want to end with telling you how eager we are as a UCLA team to listen and learn. And now I'm going to turn it over to Lisa Balin, who is our facilitator for today's meeting, to review our agenda and a few housekeeping items.
Thank you, Dr. Eisenman, and welcome everyone. My name is Lisa Balin. I'm a facilitator with Sacramento State's Consensus and Collaboration Program, or CCP. CCP supports collaborative stakeholder and public engagement processes with a focus on addressing stakeholder needs and aspirations. We work as a neutral party, and CCP has staff in Sacramento and throughout the state. I live here locally in the San Fernando Valley. I've lived here for 27 years, and I was here during the disaster. I'm going to briefly review the goals for today's meeting, our agenda, and a few process items, and then we can get started. Next slide, please. Thank you. Our aims for this first meeting are that you will come to know some of the lead UCLA team members and gain an understanding of the study's overarching goals and approach. We want to make sure that you are aware of future opportunities to participate and contribute to the study, in particular, the upcoming home air sampling program. And we also want to make sure that you have the opportunity to ask questions and share your thoughts. Today's agenda begins with a brief introduction to the UCLA team leaders. Most of our time will focus on the health study overview. This will be followed by a brief discussion of upcoming air sampling activities, as well as an overview of the plan for community engagement during the course of the study. A very important part of this meeting is hearing your questions and comments and answering as many as we can, both during and following the meeting. We have allocated time for questions and answers after each of the presentations. We tried to keep the presentations as brief as possible to maximize time for Q&A. However, I do want to acknowledge that we may not have time to address all of the questions in these time slots, but if we get through everything and we have time remaining, we will open it up for additional questions and answers at the end. But we do have to end the meeting at 1:30. So thank you in advance for understanding if I have to close any of the Q&A sessions before all questions have been answered. Following today's meeting, we will prepare a meeting summary that will include questions and responses that we discussed today, as well as those that we were not able to get to, if any. The summary will be posted on the website, along with a recording of today's meeting, as well as the PowerPoint presentation. Our in-person meeting this Thursday night provides an additional opportunity for questions and comments. The meeting will be held at Pierce College in Woodland Hills from 6 to 8 p.m. I also want to note that questions may be submitted at any time via the study website contact page. The study website is alisostudy.ucla.edu, and we'll put a link to that in the chat box. Next slide, please. We'll be using the Zoom Q&A feature today to collect your questions and comments. Please feel free to enter these at any point during the meeting by clicking the Q&A icon on the bottom of your screen. If you see that someone has asked the same question that you have in mind, please upvote that question by clicking the thumbs up button underneath the question. I just ask that you please do not use the Q&A function for editorializing about someone else's questions or comments. The chat feature will be used for the team to send information and links to you only. UCLA staff may answer straightforward questions with written responses in the Q&A box, so be sure to take a look for those. Next slide, please. Just a few meeting guidelines and then we'll get started. We ask that everybody agree to these few guidelines to make sure that we maintain a safe and civil space for this meeting. These are: treat all meeting participants' comments and questions with respect, use common conversational courtesy, inappropriate language will not be permitted. Please stay focused on today's agenda and honor our time. And with that, I'll turn it over to Dr. Michael Jarrett to introduce himself and the UCLA team.
Thank you so much, Lisa and David. My name is Michael Jarrett. I'm a professor of environmental health science, Fielding School of Public Health at UCLA. I'm the contact principal investigator for this project and leader of the Exposure Assessment Core. We'll be referring to various components of the study as cores. I've been working in the fields of exposure science and spatial epidemiology for some 25 years now. So I've concentrated on measuring and modeling environmental exposures to investigate the health effects that those exposures might cause. One of my main areas of emphasis, however, is working with communities to supply the best public health information possible to meet their needs and to improve public health decision-making. As an example, I'm currently working on a project to develop a comprehensive health tracking system for the most environmentally disadvantaged communities in California. I was one of the few independent researchers who went out during the disaster to measure air pollution, both indoors, inside people's homes, and outdoors in the ambient environment, along with Dr. Diane Garcia-Gonzalez. I was very concerned that several of the agencies involved in the blowout disaster were inferring that illnesses were being caused strictly by the odorant that's added to natural gas, the mercaptans that make the gas smell like rotting cabbage to protect people from accidental ignition. But when I saw some of the early benzene numbers coming out of monitoring that was done by various agencies, I became concerned that the exposures from this blowout could be harmful to public health. Our work led to a study, a major study, more than $1 million on indoor air quality after the blowout, in which we were able to identify specific contaminants that had likely emanated from the well leak into the homes of people living in the Porter Ranch, Chatsworth, and Granada Hills communities. We published papers summarizing this work with Dr. Garcia Gonzalez and I. I was also a member of the California Council on Science and Technology review panel that assessed the viability of natural gas storage in California. And we've made several other proposals to study the exposures from the Aliso Canyon blowout before this major study was funded. Now, this is a very large and complex study, one that draws on an array of expertise, and we need that to be successful. We have a really fantastic team with many of the best scientists in the world and many of the best medical professionals working on this. We have some 50 people involved. You can see all of the various organizations that are contributing to this research. We're working very well as a team already. We know from the work that's been done earlier in the community and from stakeholder interviews that we've conducted ourselves this year that many of you were dissatisfied with the response from various government agencies, including the LA County Department of Public Health. I want to emphasize that UCLA and all of our partners are totally committed to scientific independence and integrity. The LA County Department of Public Health has established a scientific oversight committee to review and approve our work. And they also oversee contractual obligations. I'm happy to report that this scientific oversight committee has approved the overall study design after a rigorous review of our proposal and extended meetings with our study team. The Department of Public Health has contractual and oversight functions pertaining to the study. However, UCLA will conduct the study with independence, and ultimately we will make the decisions on the best study design and methods. We will investigate thoroughly and objectively using the best science and approaches to get to the bottom of key questions that you and others have. I can assure you that we will be rigorous, thorough, and independent in our scientific inquiry. We're committed to transparency and accuracy in our communications, as Dr. Eisenman mentioned, and we have several members of our team, like Dr. Eisenman and from Sacramento State, who are extremely experienced in effectively engaging and informing communities about scientific risks and results. So I now want to turn this over to other key researchers to introduce themselves, starting with my co-PI, Dr. Honghu Liu. Dr. Liu?
Thanks, Dr. Jerry. Hi, good morning, everyone. I'm very happy to have this opportunity today to meet with our community members. I'm Honghu Liu, a professor and the chair of UCLA Public and Population Health Program. With a biostatistics, epidemiology, and population health background, I have been serving as the principal investigators for a number of large studies and center projects, including national-level multi-site collaborations that involve complex survey design and cutting-edge big data process and advanced statistical modeling. I participated in the investigation of air pollution of lung function among residents in the greater Los Angeles area back in the 90s. I'm the principal investigator of the Los Angeles County Baldwin Hills Health Assessment and Environment Justice Study, investigating the health impact from the largest urban oil production site in the US. For this important also Canyon health study, I serve as one of the two multiple principal investigators. I involved in health core leading health survey design and also lead the data core and the data and the statistical core, which is responsible for setting up the large relational databases to host the study data from multiple sources. And more importantly, to ensure data security and the study participant confidentiality. I fully understand the 2015-2016 blowout, as well as the chronic ongoing exposure to gas oil pollution, have been a great concern of this community. Your concern and needs will be carefully evaluated, considered. We will never lose sight of your concern and needs, which came from your lived experience, and will be top priorities in our study design and execution of the project. Our team will fully investigate the extent and the degree of the impact on people's health thoroughly, independently, based on the evidence and the facts from collected data and information, with rigorous scientific approach and the highest standards possible. I look forward to work with each of you. Now let me turn to Dr. Wendy Robbins.
Thank you, Professor Liu. I am Wendy Robbins. I am a professor in the UCLA School of Nursing and UCLA Environmental Health Sciences Department. The expertise I bring to this health study is based upon 40 years of practice as a registered nurse, a good part of that time as a nurse practitioner in community health clinics. Subsequently, I obtained a PhD in epidemiology from UC Berkeley and became a clinical nurse researcher, conducting laboratory and field studies on environmental and workplace exposures. My role on the project is as a co-leader on the health core. The health core is a very large core with multiple strong, accomplished clinicians, researchers, and statisticians who function as co-leaders across the different health subcores. My particular focus will be working with the clinical research team who will meet with residents in the community for the in-person research health assessments and blood sampling. Thank you. It's nice to be here with you today. And I will now turn the microphone over to Professor Eisenman.
Okay, well, hi again. We've met at the introductions to the project. I will just add that my role on this project is that I am leading the community engagement core, as well as the focus groups and also the mental health section of the health survey. So now I will turn it over to Dr. Nadi Parat.
Good morning. My name is Nadi Parat. I'm a professor in the UCLA Fielding School of Public Health and Director of Health Evaluation and Economic Research Program at UCLA Center for Health Policy Research. I have extensive evaluation expertise and have conducted a broad range of evaluations of health impact of different interventions and programs in Los Angeles County, California, and nationally for the past 20 years. I am the project director of the Aliso Canyon disaster study and lead the examination of the potential impact of the disaster on healthcare utilization of residents in areas exposed to the disaster, among other activities. I feel privileged to be able to help find answers to your very important questions on the health consequences of the disaster, which have not yet been fully answered. We hope that our work will help pave the way to promote the health of everyone that was impacted by the disaster and to be of service to this community. Thank you, and I'll turn it over to Dr. Diane Garcia Gonzalez.
Thank you, Dr. Pratt. I'm Dr. Diane Garcia Gonzalez, and I'm a project research scientist in the Department of Environmental Health Sciences in the UCLA Fielding School of Public Health. I have been working in the field of natural gas extraction, storage, and residential end use for close to 10 years. My dissertation focused on examining both indoor and outdoor environments around oil and natural gas facilities during both routine and non-routine operations. The latter included the 2015-2016 Aliso Canyon natural gas disaster, where I worked with my advisor, Dr. Michael Jarrett, whom you met earlier, to collect data during the ongoing blowout disaster to characterize air quality, both indoor and in outdoor environments. Our resulting manuscript was published in the Journal of Environmental International. I'm honored to be here today to once again work with the communities of Porter Ranch, Chatworth, Granada Hills, and other impacted areas alongside a talented team of experts to address longstanding questions that remain several years after the event. Thank you for your time. I now pass the floor along to Christina Battiati.
Hi, everyone. I'm Christina Vadiati, and I'm the Deputy Project Manager for the Health Study, and I'm also the Outreach Coordinator for UCLA's Center for Occupational and Environmental Health, or COEH. I've been doing community and environmental health research at UCLA for more than 13 years and have worked with a lot of the investigators you just met for most of that time. I've contributed to studies and new knowledge on community health effects of air pollution, built environment infrastructure, urban disasters, pesticides, toxics in consumer products, but I've always been focused on supporting the communities that have been most disproportionately affected by environmental harm. In November 2016, to mark 1 year since the disaster occurred, I supported Dr. Jarrett and COEH in organizing a symposium to synthesize all existing knowledge to date about the disaster, and had the opportunity to meet many of you from the community and your organizations then. I've been following your story this whole time, and I'm really honored to be serving this project in your community. So with that, I'll pass it back to Dr. Jarrett for the health study overview presentation.
Thank you, Christina and colleagues. I want to give you sort of an overall purview of the study, and then focus in on the part that I'm leading on environmental exposures. We understand that the community still has many concerns about the health impacts of the blowout disaster and the ongoing emissions of pollutants from the Aliso Canyon facility. Our study has two major goals. First is to understand and assess the pollutants that the Aliso Canyon facility emitted during the blowout disaster and emits on an ongoing basis. And secondly, to assess whether these exposures have contributed to health effects in the people living in the community. In other words, what were you exposed to and how could it affect your health? To answer these questions, the study has two major components, one on exposure assessment, or the exposure assessment core, and the other on health, the health core. The exposure core is using many advanced methods and measurements to identify and quantify the exposures that the community has faced. This will help us answer questions related to components of natural gas that we in the community are not able to directly get from the gas company. It will also help us to target specific pollutants of concern. The health core is using multiple approaches to quantify the potential health impacts at all life stages, beginning with in utero exposures to mothers and babies, and to other health outcomes that occur later in life, like heart disease and cancer. All of these analyses involve a defined affected area, which we have extensively studied and are defining as 5 miles to the south of the facility, downwind direction, and comparison communities that have been selected because they have similar demographic characteristics and environmental conditions. For some analysis, we have a lot of flexibility with the birth outcomes. We have statewide coverage of the data, so we can be very broad in our selection of comparison communities. Others, we have less flexibility because of a smaller sample size. Now I'm going to give you a little bit more detail on the exposure core, and then Dr. Robbins will be telling you about the health core. So the exposure core really has two main objectives. First is to identify and quantify the pollution exposures resulting from the blowout disaster that pose a health risk. And secondly is to quantify the pollution exposures that continue to come from routine operations and are potential health risks to the community. We've got several components, and if I could have the next slide, please. And this is a complex study, but I'll try to go through it briefly and look forward to your questions. We'll be conducting field monitoring to study and measure air pollutants in 40 homes, with about 20 in the first 3 miles of the facility, and the remainder at greater distances away from the community or in communities that are completely removed from Aliso Canyon. We'll be using this information to understand whether the community continues to face heightened exposures from the facility. This will begin in October, and we'll be looking for community members to host monitors. So Dr. Garcia-Gonzalez will be telling us more about that shortly. Related to this, the PSE Health Energy non-governmental organization, who some of you may know from your prior work in the community, will also be taking samples, natural gas from people's stoves, to determine the composition of that gas and to understand the indoor exposures that might be coming from natural gas leakage into homes. This will also help us to understand the composition of the gas, which will complement data that we collected from numerous reports on gas composition that were conducted during the blowout or slightly after. We'll also be using satellite retrievals to assess methane distributions and to estimate in a very detailed way how much exposure your community had during the blowout and continues to have from routine emissions. We're using methane as a marker of the air toxics that are associated with natural gas. We're also conducting a quantitative risk assessment to identify which exposures are of most concern and which of those could increase the risk for cancer and non-cancer health outcomes. This will help us to identify pollutants of potential concern from the facility and to quantify the risks that communities might face from these pollutants emitted by the facility. The exposure information will inform our studies on potential health effects. It will help us to better target clinical and other health studies toward those exposures of most concerns. And as Dr. Robbins will explain shortly, as part of our health assessment, we'll be measuring thousands of pollutants in people's blood and in the blood of babies at birth to look for unexpected differences in pollutant profiles in the blood of people in the community compared to those outside the affected area in the comparison communities. As all aspects of the study are underway, and we're making really great progress with updates to share in the coming months, certainly. In the first year of the exposure core, we're compiling data on all available exposures, recruiting for the community air quality monitoring and natural gas composition studies, conducting the risk assessment, and developing exposure estimates. So we've got a busy agenda ahead of us, but certainly one that is going very well. We're also soliciting technical expertise and guidance from the Scientific Oversight Committee during regular meetings with them and through other email correspondence. I'd like to hand it over now to Dr. Robbins for her presentation, the Health, Quality of Life, and Wellbeing Assessment.
Thank you, Professor Jarrett. The goals of the Health Core are to focus on the impact of the disaster on physical health, mental health, and well-being of residents of communities near the Aliso Canyon facility. To meet these goals, we will use multiple existing sources of health data, plus we will also collect new health information directly with community residents. We will compare the health of communities within a 5-mile range south of the well to health of communities farther away but otherwise similar. And we will look for trends in health and well-being before and after the disaster. May I have the next slide, please? For existing, more about the data sources, the existing and the newly collected data. For existing data, we will examine birth certificate records that are collected and archived by the state of California on all newborn infants. We will look for pregnancy and birth outcomes such as preterm birth, birth weight, birth defects, and this will tell us about the effects of exposures on the fetus during pregnancy. Many of the adverse health effects seen at birth can impact health throughout childhood and on into adulthood. We will also analyze 2,600 neonatal blood spots. These blood spots are routinely collected and archived by the state of California on newborns at birth. This is the heel stick blood that you see them collect on newborn babies. We will test the blood spots for traces of metabolites, for example, benzene and other toxic chemicals, and this will tell us about the toxic exposures during pregnancy. Related to cancer, we will analyze California's cancer registry records, over 100,000 statewide, to look for and document increases in specific cancers after the disaster. And we will examine all hospitalization, emergency department, and doctor visit data in California, along with thousands of California health interview survey records, the CHIS data, and other existing sources of third-party health and survey data. In terms of the newly collected data, to capture current health status of community residents, we will conduct 600 in-person clinical health assessments that include measures of lung and cognitive function, general health status, plus blood samples to test for biomarkers of exposures to toxic chemicals coming from Aliso Canyon. And in addition, we will conduct 2,000 surveys and 6 focus groups to understand the impact of the Aliso Canyon blowout on physical and mental health, as well as to document your community's resilience in the face of the disaster. The surveys and focus groups will capture both historical and current data about your community. This existing and newly collected health information shown on the slide will be integrated with the exposure assessment information from the exposure core to provide depth to our understanding of the effects of this disaster on your community's health. As a final note, I would like to share that I consider it an honor to be working with your community on this important health study. Thank you.
I'd now like to just give you a very quick overview of the timeline for our study. Next, please. So this is very detailed, but essentially we've set up all the research and data infrastructure already. We're in the process of gathering existing survey and environmental data. We've begun engaging the community, as you can see. We're collecting new environmental data, recruiting households to host the monitors for that data. We've begun to assess our adverse birth outcome data and hope to have results to share with you on that in the coming months. And we solicited technical guidance from the Scientific Oversight Committee. Next slide, please. So in year 2, we'll begin recruiting residents to conduct the surveys and clinical exams. We're going to continue the analysis of existing and environmental health data to inform our exposure models, and we'll be selecting technical expertise and guidance, soliciting technical expertise and guidance from the Scientific Oversight Committee. In year 3, we continue the survey into well-being and the clinical exams. We're going to prepare results for publication. I imagine that we'll be publishing before then on some of our results, but this will be a big year to summarize a lot of what we've done. And we'll be soliciting expertise again. And then we'll, at the end of that year, have a sort of passing point where the SOC will give us an overview of our progress to date and whether we're meeting all our critical targets. Next slide, please. And then pending approval to continue the study from the Scientific Oversight Committee, we'll continue the health and well-being assessment. We're integrating all the data, preparing that for additional results for publication, sharing the findings with the community, and again, getting more technical expertise from our Scientific Oversight Committee, who's already been very helpful in their deliberations. And then we're going to complete the analysis in year 5, share further results with community members, and select some final advice or solicit final advice from the SOC. So a very busy schedule, but we're on top of it, and we're really looking forward to working with you and sharing our results as they're available.
Thank you, Dr. Jarrett. We're going to do some questions and answers now. And I see we already have a number of questions in the Q&A box. But just for anybody who joined late, just want to let everybody know that we're using the Q&A function to collect your questions and comments. So if you haven't already done so and you have a question or comment, please feel free to click that Q&A icon on the bottom of your screen. And you'll see that you're able to put a question or comment in there. If you do see a question that's in the box and you have the same question, please upvote that comment and we'll know that there's more interest in that question. So we're going to answer as many questions as we can. And as I mentioned earlier, if there's any questions we can't answer today, we will respond to everything in the summary. So with that, let's get started with the Q&A. I think there are some questions in here that may have at least partially been answered during some of the presentation, but I'm going to go through all of them and just see if there's anything that we want to reiterate or supplement. So it seems like there's a good amount of interest in the chemical list for the natural gas, and I'll read some of the questions related to that topic. Will you be asking for the comprehensive chemical list, including fracking soup ingredients, cleaning agents, etc., from the horse's mouth, i.e. SoCal Gas, as you may know about chemicals A through G, but not about chemical H, which could be causing health hazards and also interacting badly with the known chemicals? Referring to chemistry years ago taken at UCLA. I think there was one more question about chemicals. Yeah, somebody else, we need a full chemical list. So let's start with that question.
Yeah, certainly we're going to be asking the gas company, but we have to emphasize, I don't think that they're legally compelled to share that information. So we will ask them, but we don't know what they're going to supply. We do know that there are other studies that were done and shared with the county that look at natural gas composition. We're seeking permission from their legal counsel to access those data. So, I mean, we're doing as much as we can. We're working with all the self-reported emissions data, which by South Coast Air Quality Management District regulations and California Air Resources Board regulations, the companies have to report. So we have been digging through all of that data, putting in public records requests to AQMD to try and obtain what we can get that isn't widely available. So we're doing everything we can because we realize that knowing those chemicals comprehensively is very important.
Thank you, Dr. Jarrett. The next topic has to do with the medical testing. And the question is, please explain the list of medical testing that will be offered to the public participants of the study, since as we know, there is no published medical data about the human health effects from the immense amount of chemicals the public was exposed to during the Aliso Canyon blowout. Focusing on a single exposure, for example, benzene, would be a completely incorrect approach.
Yeah, so I want to emphasize that we will be selecting people from the community But this is going to go through a rigorous survey sampling protocol. And then once we have our 2,000 people that will answer the health surveys, we then will ask for additional volunteers to participate in the clinical exam. So we can't guarantee that everybody who wants to be part of the clinical study will be included, because we're trying to ensure representativeness of our sample. In terms of the scope of the clinical exams that we're undertaking, I can say they're extensive. I draw on Dr. Robbins and perhaps Dr. Arahu to give more detail on that. But I think a real strength of this study is we're using what's known as targeted and untargeted metabolomics. So most of the pollutants have chemical signatures that are metabolites that appear in the blood. And because we are working with the world's best lab that's led by Dr. Dean Jones at Emory, that has pioneered much of this work and continues to be recognized as the best place in the world to do it, we will be able to identify literally thousands of chemicals and metabolites in the blood of the people participating in this study. And then we can use that and compare to others to see whether or not there are differences in those patterns of contaminants. So we're not just focusing on one exposure. Having said that, looking at the emissions from the facility, the field monitoring that we've done ourselves, the ongoing field monitoring that Argo Scientific is doing, we know that there are certainly several contaminants of concern, like benzene, formaldehyde, N-hexane, and ammonia that are among the largest emissions. And previously, the facility was the largest emitter of formaldehyde in the South Coast Basin. So maybe I'll turn it over to Dr. Robbins to talk a little bit more about the clinical exams that you plan and any of the other blood work that you'd like to share with the community.
Sure. We know that we'll be looking at current health status, and so we have measures of current health status. We also know that we need to look at lung function, so we'll be conducting spirometry to get evidence of lung function. We know that a number of the exposures we have identified, the exposure core has identified as things we should target. They have effects on the hematologic system and blood dyscrasias. So we'll have assays in that area. And we also will have inflammatory and immune system markers. We also are still looking at data that exist during the disaster as to what the symptoms were that were reported. And so we will also be trying to look at that and target a symptom survey related to that today. Not today, but when we actually conduct the exams.
Thank you. So the next question is kind of related, talks about the balance in the study between the clinical exams and collecting environmental data. And the question is, how much of this study will be about directly examining residents and how much will be about collecting environmental data?
Well, I mean, the study, if we're talking about the budget, there is a large component that goes toward characterizing exposures, but we also have a lot of resources that are put in there for the analysis that we haven't really talked about in our presentations. So the biostatistical analyses, the data assembly, Dr. Liu mentioned that briefly. So that sort of supports the overall enterprise. And then we have our community outreach and engagement core or administrative core. But in terms of the resources that we're devoting to the health study, that's definitely the largest component of the overall enterprise. And I'd have to go and look at the specific budget to see what percentage that is, but it is very expensive to do these metabolomic analyses. So those are absorbing a lot of the cost to draw the heel stick blood sample from the state archives on all the babies. That's something that is again very expensive too. So I would think that we're looking at, you know, a breakdown where more than 35–40% of the total budget is going toward the health study.
Thank you. Our next question partly overlaps. We've already talked about the chemical components, but there's one additional element that I'm not sure if it was addressed. So I'm going to read the question. How does the study leadership plan to overcome not having a list of the over 200 chemicals the public was exposed to? And here's the part that I think might be new, not just from the well gas composition, but the toxic garbage SoCal gas was pumping into wells as storage, as well as all of the fluids during the 7 well kill attempts, all of which was aerosolized and dispersed into the community.
Yeah, so we've been going through, you know, virtually every report that's available from Blade Energy and other consultants that worked on characterizing the well kill fluids and muds. So to the extent that the data are available there, we also have the information that was derived from the indoor air sampling, where we found when we did the analysis as part of a consulting contract, that there was a very unusual signature of heavy metals, barium, strontium, manganese, that was clustering in certain homes in downwind directions. So that is part of the matrix of the muds. So that's one of the key things that we're looking at, is how we can connect what was found in the houses to what was in those muds. So I think that, you know, the other possibility we have is we do have some soil samples that were archived by the county. We have those, and we can subject those to additional analysis to try to detect other contaminants that could have been present near the wellhead site.
Thank you. The next question notes that many residents have died or moved out of the area since the disaster, and asks how you plan to include them, the cause of death, moving away to illness, continued illness, for example, in the study.
Yeah, so we have a consulting firm that Dr. Liu is working with that is tracking residential mobility, so that we can use various data sources that are available publicly to find out who was present there during the blowout, who has moved out, and where they live. The extent to which we can still continue to track them is unknown at this point, but we recognize that this is a major issue for the people in the community, and it's a legitimate scientific issue that we don't want to miss people that have moved out because they're ill. We've also been examining whether we can get access to any of the legal settlement lists, which would indicate people that were legally entitled to compensation, and as a result, you know, are not living in the community anymore, but we know that they would have been affected. We haven't finalized that yet, but that's part of our plan.
Thank you. The next question has to do with the control group. The question is, what will your control group be looking for at air exposures at clinical exams, the 200 listed in the scope of work, and with the cancer study? The control group needs to be outside LA County because of the high number of oil and gas facilities, which could skew the information.
Yeah, we were aware of that concern. We'd seen that expressed in YouTube videos. It's a challenge because the type of modeling that we're going to employ, the more we introduce other heterogeneities, for example, if we went to the Central Valley or to the Bay Area, there are so many other environmental and social factors and contextual factors is what they're called in the spatial epidemiology literature, that we could be introducing significant sources of differences between those populations that are not quantifiable. So to the extent possible, we do want to have control areas that are close to LA County, if they're not exactly in it, but are removed from oil and gas facilities. So we've obtained the entire list of locations for all the active wells. And we've either quantified those potential control areas that are affected by wells so that we can look at those as potential counter matches, because there are wells operating in the Aliso area still, not just the storage wells, but there's also ongoing hydraulic fracturing in some of the facilities that are related to that field. And then we also have identified areas that are completely devoid of oil and gas operations in Orange County and in Ventura County. So those are certainly prime targets for our health recruitment, because we want to make sure that we address that community concern. But if the further we go afield, the more we introduce heterogeneity and the more we introduce the possibility that there are other factors that are affecting people's health that are not comparable. So that's the major issue we're trying to avoid.
Thank you. The next question asks, please explain what % of the study is going to look at the chronic, acute, chronic nature of the ongoing exposure from Aliso Canyon. Data shows that Aliso Canyon leaked long before the blowout disaster and continues to leak after the disaster.
Yeah, there's certainly evidence from the remote sensing that we can see that there are ongoing releases of methane. They are much smaller, however, than what was experienced during the blowout disaster. We don't have good information that I'm aware of on the emissions that were occurring before the disaster, because this disaster actually spurred a whole new field in the remote sensing area where people began to use satellite retrievals to better monitor methane. So what we're able to do for the acute effects during the disaster is to look at the birth outcomes. So any of the pregnancies that intersected with the approximately 3.5-month period that the leak was ongoing. So we can look at the acute effects on birth outcomes. We can look at acute effects for the hospital utilization and physician consultations. And we can also look at other data that has before, during, and after, which we plan to do with the neonatal blood stick samples and the metabolomic analyses. In terms of the chronic exposures, much of what we'll be looking at in terms of our clinical assessments, because they're coming a long time, about 8 years after the event, those are going to be a representation of the longer term chronic and potentially the acute exposures from the disaster. And we will be using additional statistical methods that help us to parse out the acute versus the long-term. But ultimately, when we do the clinical assessments, because they're coming afterwards, those are going to be a representation of a long-term exposure. And then we have the cancer outcomes where the latencies are quite long. So we would consider those long-term exposures. And we hadn't mentioned this explicitly, but we're also using the California Health Interview Survey data, which is available before, during, and after. So we can, it's not what I would call truly acute in the sense of being less than a week or, less, but it's something that's shorter than, chronic, which is generally defined as a year or greater, but long, so we call it subchronic exposures.
Thank you. The next question notes, my son, who was 5 during the blowout and thus significantly exposed, suffers from nosebleeds and headaches. How does the study plan to address the exposure differences between higher mass individuals, i.e. adults, versus lower mass individuals, i.e. babies, toddlers, and young children? Yeah,
so during our risk assessment analyses, there are reference exposure levels that we're assembling, and those apply to both children and adults. There are differences in the way that children absorb chemical exposures. Their breathing rate tends to be higher. They're growing, so their tissues are more vulnerable to penetration of the contaminants. So we are taking that into account in our risk assessment, and we are looking at in utero exposures that really, result in adverse birth outcomes and in unusual patterns in the metabolite profiles of the in utero blood sticks. I don't know, Dr. Robbins, if you have any other comments, or if any other panelists want to comment on
that. In terms of the blood spots, though, we are looking at blood spots before, during, and after. So those have been maintained in a way that we will have data for those time periods from the neonatal blood.
Thank you. The next question asks to please explain in detail how the study leadership will guarantee independence when DPH is responsible for the final publication of the report. Your group is responsible to design, conduct, and evaluate.
Well, I think we've laid out with them that we are scientifically independent, that we are going to take the advice of the Scientific Oversight Committee and use that as best we can. But ultimately, we're going to be the ones signing our names to the papers that come out of this work, and we have to feel 100% certain that we are employing the best methods in science that we can, and we will not deviate from that, regardless of the advice we might receive from the Scientific Oversight Committee. We meet with the Department of Public Health on a regular basis every 2 weeks. These are contractual check-ins to make sure that we're making progress, to try and work out the many little administrative issues that seem to arise with a study of this size. But we are operating independently from them, and they understand that as well, I think.
Thank you. The next has a few different, I think, comments and questions in here. How does the study plan to overcome years of misinformation from SoCal Gas as to the exposure and importance of the exposure to the affected community, which the commenter noted he feels respectfully greatly extends past 5 miles. 5 miles due south extends only to Plummer Street, southwest to Devonshire, Tampa, and east to Woodley Avenue. I, for one, have data that at least implies the health effects extend outside that range. So the question is, how did we come up with the 5 mile range, and is there any evidence or consideration to go further than that or collect data from the community to that point?
Yeah, that's a good question. We've done a lot of work trying to characterize where the exposures are likely to be elevated. And that includes taking the remote sensing satellite retrievals of methane during the event, which we take that as a sentinel marker of the air toxics that could be bound up with the natural gas. It's the largest constituent of natural gas, and in our previous work, we found very high correlations between, for example, benzene and short-term emissions of or elevations of methane. So in those remote sensing retrievals, we see a maximal distance of influence before reaching background of about 3.5 miles. We examined all the complaint data and looked at the percentages of complaints that were coming. I think it's something on the order of high 78%, something like that, that are within that first 5 miles. We also have calibrated a chemical transport model, which takes into account all the emissions that are coming from the facility, and then looks at their potential transformations in the atmosphere. That too indicates that for key contaminants like benzene, we're probably looking at about 3.5 to 4 miles. And then finally, we had methane monitors and data that were operating at distances that are close to the 5 miles, and we don't see a lot in those monitors that's above background. It's entirely possible that there are people that were outside of the biophysical impact zone who had psychosocial impacts due to the distress that was being caused to the communities that were close to them. We will be examining in several of our health data, not just sort of control communities, but looking at whether we can get what's known as a distance decay gradient. So in other words, as we get farther and farther away, under the assumption that farther away means likely lower doses from the facility, do we see a drop off in certain medical conditions and symptoms? And that's something that we can track with our administrative data, and we'll certainly be doing that as well. So while we're defining the key impact zone as within the 5 miles, we are going to be examining health data that goes out beyond that, looking for these decay gradients. But all of the biophysical data that we've extensively developed ourselves, examined, or collected indicates that 5 miles is probably the best characterization for the impact zone for the blowout disaster.
Thank you. The next question says, what types of cancers are you examining as part of this study? And in what ways will you include individuals who have been diagnosed with cancer since the disaster in this study?
Well, we have, several blood cancers that are top candidates because they're linked to benzene exposure. We're certainly looking at potential cancers in other major systems. The issue is that there's very long latency period for some of the cancers beyond the blood cancers. And because the impact zone is relatively geographically constrained, the numbers that we'll get are going to limit us in terms of having the statistical ability to separate out effects. But at this point, we're definitely targeting the blood cancers, and we're looking at other cancers that have plausibly been linked to some of the contaminants that we know are being emitted on an ongoing basis from the facility, and seeing whether we can do that. But we also have the capacity, because we have all of the cancers, is to assess other cancers. And we would, if you're members of the community are particularly concerned about certain types of cancers, we can do those investigations, but recognizing that those that have very long latencies, longer than 8 years, are unlikely to be showing up as elevated if it was a result of the exposures during the blowout disaster. So that's part of the limitations that we have. The risk assessment that's being led by Dr. Tom McCone at UC Berkeley, who's one of the world's leading experts in this, we're examining the potential of the likely exposures, what they may have done to cancer risk, and using that to help guide our assessment. And then Dr. Liu has independently been looking at all of the contaminants from oil and gas production in general, and any of those that have been linked to cancer outcomes.
Yeah, I'd like to add a little more on this topic. This is very important. I'd like to let the community know our team will do a thorough cancer analysis. As Dr. Jerry mentioned, based on literature, oil gas pollutant has actually high likelihood related with hematologic cancer, which is blood cancer. But to be safe, we will actually look through the other cancers as well, because we do have the full data. We will have data from California Health Map, which has 12 common cancers we already did quite some analysis, and we will have the detailed individual cancer information from the California Cancer Registry. And that we will be able to look at all different cancers beyond the blood cancer. We also will have information later for the survey part, even ask about potential cancer of neighbors who moved out. So we actually have multi data sources be available for us to conduct a thorough cancer analysis.
Thank you very much. And I just want to note, we have about 38 attendees on this webinar today, for anybody who's interested in how many people are here. The next question asks for further definition of short and long-term effects. It says, what do you mean by short and long-term effect? It has been 8 years already, which is a long time. And what do you expect to find in our blood after 8 years?
So just on the first part of the question, we normally define effects as in toxicology and environmental health as acute being less than a week. So those effects where we might see elevated risks for going to hospital or consulting your physician would fall into that category. The chronic, as I mentioned earlier, is generally considered to be exposures that accrue over a year or more. And then something that's been less well studied is the subchronic, meaning somewhere between that week and year length. So when we look at the data administratively, we can look at those acute effects, as I mentioned earlier. But as we go into our clinical assessments, we're talking about the accumulation of long-term exposures. What we are doing, though, is we're looking at all of the available literature. We're consulting with oncologists at UCLA to try to see what the leading edge is on biomarkers that indicate that someone may have been exposed to a carcinogen many years ago. And we'll be extracting data on those as we're able to from our metabolomics analyses. I don't know if Dr. Robbins wants to add anything there, or if anyone else would like to add anything. No, so.
Nothing to add. Okay, thank you very much. We're going to take about 2 more questions right now, and then we're going to continue with our presentation. And I think and hope we'll have time at the end to get back to Q&A. So the next question is, we know there is no known correlation between levels of methane and levels of dangerous chemicals, i.e. benzene and formaldehyde. So how are you going to overcome that lack of correlation?
Well, I mean, certainly we've observed very strong correlations between benzene and methane, where we did detailed analysis that we published in the journal Environment International, which is one of the most highly ranked environmental health journals in the world, where we looked at the so-called trigger samples. So when there was a oscillation of methane that was above 5 parts per million, so about double the background, or a little bit more than double the background, that triggered a canister sample, and then there was a gas chromatograph analysis done of it, and we looked at the correlations and found that for many of the air toxics that we had surmised would likely be part of the matrix of the natural gas and the trace elements, that those had extremely high correlations with methane. And there are other data showing similar results from other locations where oil and gas operations and natural gas. And then in addition to that, we have information on the whole or raw or unburned natural gas that we'll be collecting, which will give us information about how strongly the trace constituents like benzene correlate with the methane, and the natural gas that's being used in people's homes. I don't know if our PSE colleagues would like to comment on that, if they're able to jump in. I'm not sure of I think it's possible that we could have Eric LaBelle comment on that.
And I can unmute.
Drew.
Thank you. It seems like somebody already did that. Actually, I'm not seeing.
Or maybe it's Drew McKenowitz. So we need to unmute Drew McKenowitz.
Not seeing them. Oh, here we go. Drew, you should be able to speak now. You just need to unmute yourself, I think.
We're not hearing you, Drew.
Yeah, Drew, are you able to unmute? You have the permission to unmute, but I think you need to go ahead and unmute yourself. I'll give Drew a minute to get that sorted out, and we'll take the last question and come back to this if he's able to work that out. So the last question is, will all Porter Ranch residents be sent the health survey?
I can answer that question. Yeah, we have rigorous design. The design is address-based sampling. So as mentioned earlier, we were focused on the 5 miles radius from the well 25, the wellhead southward. And so the sampling will be a stratified sampling, random sampling, and stratified by race, ethnicity, and the social economic status. And the third dimension will be the radius distance from the wellhead 25. So people within this 5 mile radius will have the equal opportunity within each of the stratum, which is defined by 3 factors: distance from wellhead 25, race, ethnicity, and the social economic status. Within each the stratum, every household will have the equal opportunity being selected.
Okay, thank you so much. We're going to continue now with the next part of our presentation, which has to do with the air monitoring. And I'm going to turn that over to Dr. Diane Garcia Gonzalez.
Thank you. So over the next.
Sorry, Dr. Gonzalez, I just want to note that Drew might be coming on and able to continue that answer to his question after your presentation.
Absolutely. Thank you, Lisa. So over the next several months of the project, we'll be focusing on characterizing air quality around the Aliso Canyon natural gas storage field via on-the-ground field sampling. Data collected during this time will be used to inform various project tasks, including the risk assessment, the exposure reconstruction, cancer assessments, and other aspects of the exposure and health course. With the community's help, we will aim to recruit several households to participate in the field sampling by hosting air quality monitors over the course of the next year. We will select qualifying homes located at varying distances from the natural gas storage field to both characterize residential air quality and better understand how air quality may change as distances from the storage field increases or decreases. We aim to monitor both indoor and outdoor environments, as well as indoor natural gas samples collected directly from gas cooking stoves in a subset of these locations. In addition to air monitoring, we will also conduct a survey that will help inform us on your indoor environments. It's important to note that participation in this part of the study is not an enrollment in the health or clinical studies. This sampling is only meant to collect environmental data, and no personal or health questions will be included in the survey. Specifically, we aim to collect 3 main categories of samples: unburned natural gas samples from residential stoves, ambient air samples or samples taken from right outside the home, and indoor residential air quality samples. Next slide, please. The sampling devices for the latter two, which I had described as both indoor and outdoor sampling, are detailed on this slide. The devices include a small UPass monitor, which measures particulate matter or particles that are 2.5 microns or less in diameter, as well as metals, a purple air sensor, which measures various size particles, and a passive air sampler that will measure polycyclic aromatic hydrocarbons, or also referred to as PAHs, which are a class of chemical that occurs naturally in coal, crude oil, and gasoline. Please note that these devices will be left in the homes for at least 4 weeks, 2 weeks in the fall or winter of this year, and another 2 weeks in the spring or summer of the following year, 2024. They're expected to have a minimal impact on your indoor environments. These devices make the noise equivalent to a spinning ceiling fan and consume the same amount of energy as your average toaster. Next slide, please. In a subset of these homes, we will also collect samples of gas directly from gas stoves. This method focuses on understanding what pollutants and other substances are in the gas before it is burned, with the aim of understanding the health impacts on individuals who were exposed to a gas leak. We will be testing for air pollutants such as benzene, hexane, methane, volatile organic compounds, often referred to as VOCs, sulfur-based odorants, and other hazardous air pollutants, often referred to as HAPs. Samples will be collected in a specialized evacuated canister, as shown in box 8 of this slide, which will be directly connected to your stove with a hose to capture the unburned gas. The natural gas sampling will be conducted by our colleagues and co-researchers, Dr. Eric Labelle at PSC Healthy Energy, who led the study titled Composition, Emissions, and Air Quality Impacts of Hazardous Air Pollutants and Unburned Natural Gas in Residential Stoves in California. The article is shown at the bottom of the slide and was referred to in the Q&A questions, one of the Q&A questions. The study included, this study that they had conducted and published included samples from residential homes within this very community. Some participants in that study may actually be on this call today. We aim to begin recruitment in the next few weeks, and we'll continue to recruit until we have sampled a total of 40 homes in our targeted areas. Investigators will take a few hours to set up the devices in the home during the first week and continue to monitor indoor and outdoor environments for a total of 2 weeks. The first 2-week sampling timeframe will repeat itself in about 6 to 9 months to capture samples in an alternate season. The unburned natural gas sampling from your stove, which only takes about 30 minutes to complete, will commence with the indoor and outdoor sampling and repeat every other month until the end of the field sampling timeframe for a total of approximately 6 samples per home. Repeated sampling from the same location over this longer period of time will allow us to better understand the seasonal variability of pollutants measured in the gas, in homes, and outdoors. We encourage you to visit our website and sign up for our email list to hear more about how you may be able to enroll your home in this air monitoring study. Please note that depending on the level of interest in the community, we may not be able to accommodate all homes that have requested to participate. Additionally, enrollment in the air quality study does not guarantee that we will be able to accommodate all 3 sampling methods I had outlined here today. Thank you for your time, and I look forward to any questions that you may have.
Thank you. We have about 10 minutes to take any questions specifically related to the air monitoring program and participating in that. I'm not seeing any in the Q&A box, but I'll give it one more minute to see if anybody has a comment particularly related to that. Okay, we can also get to those in the additional Q&A at the end if anything comes up. So with that, I'm going to turn it back to Dr. Eisenman for a brief review of our community engagement plan.
All right, thank you. So, hi again. I'm leading the community engagement aspects of this project. And by community engagement, I mean how we plan to make communicating between our team and you, the community, a crucial aspect of our work. So allow me to spend 5 minutes describing the what, the how, and the when of our community engagement. So first of all, what is our community engagement team's job? So our job is to increase awareness and understanding of the study through frequent, regular, easy, and transparent communications. We will be providing regular updates on our progress, including about study findings, well before they are distributed to the broader public through journals or other methods. We will be keeping you informed about opportunities to be involved in the study, such as the home air monitoring that Diane just talked about biological sampling, focus groups, and surveys, and the health assessment. We are already providing easy access for your questions about the study. Please go to our website and you will see under Contact Us a section where you can leave a comment or question. And I already have been answering some of the questions with personal phone calls. So how will we do this? First, we started our engagement work with an independent assessment conducted by our Sacramento State colleagues of the previous community engagement approach under the Department of Public Health. This included a comprehensive set of interviews with representatives of the former community advisory group. Based on what we learned about their approach and its challenges, we prepared a comprehensive community stakeholder communication plan that describes how we will reach out to and engage with you, the community, and do so in a way not previously experienced by you, the affected community. A draft of that plan will be publicly available very soon, along with that independent assessment conducted by the Sacramento State colleagues. An important element of this is we will assemble a network of community members to participate in a community engagement support and advice network. This network will be made up of representatives from local organizations such as the homeowners associations, neighborhood council, schools, religious groups, churches, synagogues, etc. And this network will advise us on outreach, communications, and engagement methods and venues. For example, the network may provide input on a specific study element's recruitment methods. The network will help us to reach some of the more susceptible people in the community in terms of health impacts, such as older adults, pregnant and nursing persons, and language groups such as Korean, Armenian, and Spanish speaking. The network will let us know about community questions and concerns about the study. And they will help with an ongoing assessment of our engagement effectiveness. Second, please join our email list to receive updates and notifications of future meetings in our Facebook page. I will give these on the next slide. Our study website is up with a place to send your questions, as I mentioned. And third, we will be holding periodic community meetings such as this, both in person and virtual. So that was the how. How will we do this? Now for the when. When will this happen? Well, starting right now. Next slide, please. Here's our website, our Facebook group, and our email signups. We will be assembling the Community Engagement Support and Advice Network soon, and will meet formally twice a year. We plan to recruit for the focus groups this winter, and we'll be announcing study finding meetings about the study findings that we are having as soon as results are available. We plan to continually evaluate and improve on the effectiveness of these meetings, and to that end, we would really appreciate if you could fill out the brief evaluation form, a link to which can be found in the chat box. You will also receive an email following this meeting that will include the evaluation link. So that is the end of my presentation, and I will take questions if there are any.
I'm looking through the box to see if there's anything. Here's a question regarding outreach. They're asking if we'll be using nextdoor.com.
We are not planning, we have not yet planned to use nextdoor.com, but that's an excellent suggestion. If people feel that that's adds substantially, we'd be happy to consider that. I'm not sure if there are any limitations on us being on Nextdoor, as we are not in that zip code, but we might be able to find a way to make that work. Thank you for that suggestion.
Thanks. And I think we need a local resident to support us on Nextdoor. So perhaps we'll work with local residents to make that happen. Okay. Another question regarding community engagement. How is the study going to overcome the immense apathy in the community, the lack of knowledge of the importance of the study, and how everyone who lived within a certain distance, per the study 5 miles, was exposed, whether they realize it or not? Lack of community participation should be a very real fear the core team has, as it has been what we've experienced now for 8 years.
Well, thank you for that question. That is something we'll have to work with this community engagement support and advice network upon. I mean, only people like yourselves will really know how to get into the community in ways that engages them, gets them excited to be part of the study, gets them involved and volunteering to be part of it. That might mean going and speaking to groups and different venues on different occasions. That might mean advertising in ways that you suggest are effective. That might be using language or highlighting ideas that you think your neighbors will respond to. So, that is exactly what we hope that our engagement, support, and advice network will help us with.
Thank you. The next question regarding engagement is, how will the members of the advisory committee be selected, or the network, I guess, which would be the case here? Also, our plans to meet only 2 times per year, is that correct?
So we have a substantial list of organizations and different groups that are existing in the communities, and we want to have a broad representation across a lot of different sectors and sections of the community. So we'll have to make sure that we have some diversity in age, some diversity in other demographic factors, that we have geographic diversity, that we have representation from key groups. And we're really going to make sure that we go through that and invite persons from those different sectors, different organizations, in a way that really represents the broad swath of the community. Yes, right now we're planning twice a year for formal meetings, but there will probably be opportunities for meetings in between then too. And that's really, we plan to be responsive to those kinds of needs.
Thank you very much. Just taking a moment to see if there's anything else regarding community engagement that hasn't been answered. I think we've covered that. Dr. Eisenman, do you want to just give a few closing remarks for anybody who might not want to stay for the additional Q&A section? And then we can go back and pick up where we left off.
Okay, yeah, absolutely. So I just want to, for those of you who don't want to stay for the additional Q&A session that's going to come, we want to thank you for coming. Please sign up for the email list, and you will be getting an evaluation. It's in the chat box now. I'll be getting an email with the evaluation. Please evaluate this session for us. We can only learn from you. And we look forward to seeing you at future meetings. So thank you very much. I'll hand it back to you, Lisa, for the Q&A.
Thank you. I believe there was a question that might not have been fully answered during our previous round. And I think it had to do whether or not everybody in the community would receive the study. And if I didn't get that right, please put the question in the box, and I apologize if we didn't fully answer it before.
Yeah, I clarified in the Q&A. Let me just quickly describe it again. So as I described the algorithm, which is the 3 factors, and everyone will have an equal chance to be selected. We, however, will only send the invitation letter to those who will be selected through our algorithm. We will not send a letter to every single household. However, again, everyone will have the equal chance to be selected. And in terms of that, yes, everybody will participate. However, the letter will only go to those who will be selected through our algorithm, which is designed by the 3 factors, as I mentioned earlier: the distance to the WW25, the wellhead, the social economic status, and race ethnicity. So we'll have those stratum. Within each stratum, we'll select a certain number of residents. Everybody will have equal chance to being selected.
Yeah, and I think it's important to emphasize that our intent here is not to exclude anyone, but it is to ensure that we have a sample that is as representative of the community as possible. If we just send out the surveys to everyone in the community, some people that are more motivated to respond or have more time might respond. They might not be representative of the overall community, so it runs the risk of biasing our sample. So the algorithms that Dr. Liu and his team and his consultants are putting together are intended to give us as representative a sample as possible and to avoid those biases that might occur if we just sent them out, to everybody in the community and then took whatever responses we got.
Thank you. And I just wanted to see if I could just take a moment to expand on one of the answers we gave before about meetings. So this CSAN, this network of community members that's intended to help support us mostly with engagement and outreach to make sure we can reach you the best way that we can, that we're planning for 2 meetings a year, but we may also have email communications between that. But I just want to make clear that that is in addition to meetings with the entire community, and the subject matter is different. So with the CSAN, we're going to let them know we've got meetings coming up. How can we best reach people? How can we deal with the apathy? How can we do a better job at finding a facility closer to the community? Questions like that to help us. The meetings with the community are going to be about the study, the subject matter. We're planning on having at least 2 meetings a year like this with general updates. We may have additional meetings about specific topics as they come up. When findings are ready, to be reported, we may have additional meetings. So just want to make sure there isn't any, misunderstanding about the CSAN versus the general community meetings and the frequency of that. So with that, let's get back to the general Q&A box. Is a question directed to Dr. Jarrett. In your participation on the CCST report, how will the study overcome the lack of knowledge of chemical exposure is not only insufficient in its sampling process and incomplete list of and usable for health risk assessment? Why repeat the same flawed approach? Isn't this a logical reason for the study to rely on full clinical evaluations?
Well, I think, yes, we don't have the complete list, but we do know a lot of the chemicals that are coming out of this facility that have known health effects. And if we look at the benzene, toluene, ethylbenzene, xylene, and hexane, and several others like formaldehyde, ammonia, we have well-documented information on those health effects. We'll be concentrating on that. We are using the clinical exams to try to identify broader biomarkers of, say, inflammation and immune response that could be disrupted by a very wide array of chemicals. And then we're using this untargeted metabolomics to identify unusual metabolites that are occurring in the community that's been affected by the blowout or is affected by the ongoing emissions, and comparing that to other communities quantitatively with very rigorous statistical methods. So if there are unusual metabolites appearing in the blood of people living in the affected communities, we're going to find them, and we're going to identify them, and we're going to quantitatively compare them to others that are outside of the impact zone. So I think that that's probably our strongest way of dealing with this. The other similar blood analysis that we'll be doing 2,400 blood stick draws for the in utero exposures will also yield similar types of information. And that has the advantage that we can do it before, during, and after the event. So we can look at not just changes that have occurred between the comparison and the affected communities, but we can also look at temporal changes that could have occurred in the affected community before, during, and after, using the before as a baseline, which I know isn't perfect because the facility was emitting before the disaster, but it's the best that we can do with the information available. So I think, that's going to yield a lot of information on the potential contaminants. And then there are other methods that Dr. Jones and his team at Emory have developed where they can use this untargeted metabolomics to try to pull out signatures of known chemicals so that we might not be completely certain they're being emitted from the facility, but we will be able to pull out chemical signatures. And Dr. Beata Ritz, who couldn't be here today, is one of the world's leading molecular epidemiologists who has worked with Dr. Jones for probably 15 years now, using these methods for very similar analyses. And I can say that we get very good agreement between known chemicals and the benzene signatures, but also we're able to identify other chemicals that are not as common through these metabolomic profiles.
Thank you. Our next question is to Dr. Robbins, a request to please provide more detail on the clinical protocol, sample sizes, control group identification process, and timelines.
I think Professor Jarrett showed the timeline that the clinical exams are targeted for the second year of the study. And so I don't know if we can show the timeline again, or but that is when we're planning to get started on that. And in terms of the clinical assessments, we'll be conducting assessments of current health status. They'll include physical measures, blood pressure and BMI and things like that, and also the spirometry for lung function. There'll be a cognitive screener. In terms of specific blood measures, there will be measures that will target blood dyscrasias, as Dr. Jarrett mentioned, inflammatory and immune system. We have measures that will look for cardiac health, and the metabolomics, I think, will be very, very important. I hope that helps.
Thank you, Dr. Robbins. Okay, we have some additional responses about the chemical components. So I think I'm going to group those together in a moment, but get to some other topics and come back to that. Let's see. This is a question about the process with SOC review. What if you disagree with SOC, which is primarily government appointees with no experience in such studies? How will you resolve? Also, will there be an independent publishing of the UCLA study methods, findings, and conclusions?
Yeah, so I mean, we have a process with the SOC. We have already had some disagreements with them, but we've worked them out either through written response, where we said, well, no, we don't think that, you know, you're taking us down the right path. Or in our meetings, we've discussed it with them. I would say overall, they've been very thorough and rigorous in their comments, but they've also been willing to listen to counter arguments. So that's what we presented to them when we think that they might be asking for something that isn't in the best scientific interest of the study. I would say that I don't think it's necessarily fair to characterize the government officials as not having experience in these areas. We do have some officials that are, environmental consultants, retired, emeritus professors of the, deans of schools of public health. And we have people from OEHA that were, professors at internationally recognized universities for 15 or 20 years before shifting into government. So they're extremely knowledgeable toxicologists and environmental health scientists, regardless of whether they're, in government. And many of them have engaged in disasters. They've engaged in trying to look at chemical exposures when the mixture was not fully understood. So I would say that we have a very skilled team. We also have some people that are, professors of environmental health departments and chairs of environmental health departments who are very well renowned in the field. So on that part, I think that, we have to recognize they have a lot of expertise, and, ultimately we have to make the decisions, and we've made that clear to them. And there's a process where they can vote us up and down. So far, they have voted in favor of our study design after we explained it to them. I think we had something on the order of 60 pages of responses to their first round of queries. So in that, we did have to point out several times where we felt that, what they were recommending wasn't either A, feasible with the data that we could acquire, or B, wasn't desirable because of methodological issues. And they've accepted that.
Thank you. The next question is, will the report include specific recommendations for future mitigation of health impacts?
Sorry, can I just go back to that previous question? Because I think I missed one part of it. It was a triple barrel question. I only got two. But the third is, will we be presenting our results independently of a final report? And the answer is absolutely yes. We'll be publishing our results as rapidly as we can, recognizing that the community has a lot of concerns. And, it's always hard to predict when the publications will come out, because the peer review process is often lengthy and hard to, target in terms of timeline. But we will be submitting numerous papers independently. Those papers will undergo review by the SOC and by the county prior to submission. And we are committed to also conveying early results to the community, recognizing that some of these could change in the peer review process, because that process oftentimes does turn up things that maybe we hadn't thought of. And, usually that improves the paper. So, but we will be reporting independently on an ongoing basis, and are committed to sharing our results with the community as quickly as we can.
Thank you for adding that to the last question. Just as a reminder, the next question is, will the report include specific recommendations for future mitigation of health impacts?
Yes, absolutely. So we will be, to the extent that we can do that with our results, if there are obvious exposures or contaminants that are of concern, or we're seeing health signals that are consistent with what we might expect from exposures from some of the chemicals that are being emitted from the facility, we will absolutely recommend possible measures. But I think that, we're not necessarily experts in how to run natural gas storage fields, we're studying their emissions. So there may be aspects of it that are, where we can give more general guidance, and then we have to leave it to the regulators to deal with the specifics.
Thank you. Here's a question about the cancer analysis. I have numerous neighbors who have died of cancer in the 22 years I've lived in Porter Ranch. Do you plan to compare overall cancer occurrences and deaths in the area of the blowout to other areas of Los Angeles over a period of, for example, 20 years to determine if cancer rates are higher in our area?
Yeah, so we have requested all of the cancer registry data for a period that extends to about 5 years before the blowout, and then 5 years or up to the latest we can get. There's usually a 2-year lag, so that would bring us to probably 2022. And with the cancer registry data, we'll have virtually statewide coverage for comparison, with the exception of the Bay Area, because the request there requires a different process, and we feel that the exposures there are probably quite a bit different than what you would get as a background in the San Fernando Valley. And I did see in the chat box, there was another question about the risk assessment versus looking at the actual cancer data. And we absolutely think that, it's essential to do both, because we want to be thorough in our assessment of the cancers. And we want to, do the comparisons in areas that have no oil and gas. We can do that because we have virtually statewide coverage. But it's also important to understand, when we look at results, if it's plausible that certain outcomes would show elevations. If there are such low exposures to benzene, for example, I'm not saying that they're low, I'm just saying this would be an example. And then we find the hematological cancers are highly elevated, we would want to interrogate that and understand why. And maybe that is a hint that there's another chemical there that we're not able to directly measure or don't know. And maybe it's a hint that there could be other factors that are contributing to those elevated rates that would not necessarily be part of our standard risk assessment. But I think it's important to do both so that we can triangulate our results between those results that are meaningful and plausible and those that are unexpected, and try to give full explanations for both.
Thank you. The next question here says, if I have been diagnosed with a blood disease, how would you know, and would you want to include me?
Well, I guess it would depend on what kind of blood disease that was. Whether that's a blood disease that's a cancer that's reportable through the registry, or whether it's some other blood disease that's not standard reporting. We have requested a wider array of biomarker data from Quest Diagnostics. We're waiting to get their final estimate on that so that we can look at diagnoses of various blood diseases and compare them. We understand from examining some of the YouTubes and commentary from the community that they weren't satisfied with the control areas that were selected for that exploratory analysis that was done by the county. So we're looking at a broader swath of control areas, and particularly some that are not having oil and gas development. So we could find out through that. And the routine health records would usually be emergency room and hospital admission data. We're working with our UCLA Health system to get the physician consultations as well, which would then also allow us to look at various blood disorders. But at this point, we don't have those data in hand, and we're still working through very new processes to get access to those. The hospital admission and ER data is available, but that's usually just the tip of the iceberg, the very severe cases when somebody has to go to the hospital. So we're trying to get a more comprehensive swath of data from the medical providers associated with UCLA.
Thank you. Next question, do you have access to AQMD air sampling that was done during and shortly after the blowout?
Yeah, as part of our work, we've been in regular consultation with AQMD staff. I think some of them are here today. We have been informed that we have to put in a public records request to obtain that. We're in the process of formulating that so that we can get all of the data that was collected by AQMD during the event and shortly thereafter. We do have quite a bit of it that we collected as part of our earlier investigations, but we'd like to get the complete data. And I think they'll be cooperative, but there is a process for that, and we're in the middle of that process right now.
Okay. We have a question. Are you looking at the possibility of our gas stoves emitting toxic chemicals into our homes? I think we had a presentation on that earlier. I don't know if anybody wants to add anything on that.
Yeah, I don't know if we were able to get Drew Kanowitz on the line, or is he available now? And we had a little technical problem.
I think he is.
Hey, this is Drew. Can you hear me?
Yes.
Hi, Drew.
Perfect. Sorry about that earlier. So to the extent that we will be measuring emissions from gas stoves, as Diane mentioned before, we will be collecting gas samples from gas stoves. So this is basically to try to figure out what else is in gas before it's burned. Also, we will be monitoring indoor air quality. That will include emissions while typical daily activities are being done. So that may include cooking. So it's possible that we may, capture some emissions associated with gas stoves, but certainly this study is focused on broader questions. But that is really the extent that we would be thinking about gas stoves in homes.
Thank you very much. Okay. We have a question. Do we hope about the outcomes of the study? Do you hope from this study to be able to provide to regulators and other community members? I'm sorry, the box just kind of moved on me, so I lost the question. Let me see if I can find that. I think it had to do with standards for safe, for exposure levels. And I don't know if that comment got moved to answered somehow. Hold on. That was from Dr. Hector. And the question disappeared. Let's see.
Lisa, do you want me to read it?
Yeah, thank you. Yeah, for some reason it's lost it in my box. Thank you, Nadi.
Do you hope this study will be able to provide to regulators and other communities sufficient information to establish standards/limits about the natural gas health hazards from exposure? To the best of my knowledge, safe standards have not been established. Am I wrong?
Yeah, so I mean, our interest is supplying the best science we can to inform public health decisions. So that's something that we'll be looking to do. Whether those influence the regulatory process is beyond our control. And we're not in the business of setting standards. As I said, if there are general recommendations that we can make in our final report, we will certainly do that. But I don't think that there are existing standards for natural gas. We certainly have many reference exposure levels that are for those toxic constituents of the gas that we can refer to. They are oftentimes in residential areas rarely exceeded. And the concern is, are we seeing something that's a chronic low dose exposure that's resulting in health effects? So this study will help us to understand where there's some of those chemicals at lower than reference exposure level doses are associated with health effects. So we will supply the science, but really where it goes from there beyond our general recommendations is going to depend on how it's perceived by regulatory communities.
Thank you. We have kind of a comment and a question. Can we agree that this study would be a huge disappointment to the researchers and impacted community if the study is inconclusive and states, quote, "the situation requires additional study"?
Well, I don't know if I would be disappointed. I mean, I don't think we're going to come up with a recommendation that says in general we need additional study. There could be areas that we feel that we didn't have the data or the capacity to collect the data that could require additional study, and if that's the case, we'll recommend that. Whether it's a disappointment or not, I mean, I understand the terrible trauma that the community has had inflicted upon them from the blowout disaster and then all the subsequent worry. That's something I totally empathize with. I was out in the field 2 or 3 times a week during the blowout disaster, and I wish that I'd known more about what I was being exposed to then. So I had my own concerns. But as scientists, we don't start a study trying to find something positive or negative. What we do is try to execute the very best methods and rigorously examine the data and present our results as honestly as we can. And that's all we can promise, is that we'll be rigorous, thorough, and use the best scientific methods that we possibly can to get at those questions. So whether that results in completely no findings is still an unknown at this point. So I, as a scientist, I'm not disappointed if I find or don't find things. But that remains to be seen.
Thank you. We've got about 3 minutes left, and I want to acknowledge there's still a lot of questions, many of which have to do with the chemical components, and we have talked about that for some time. But I want to just give an opportunity to Dr. Jarrett if you see anything else in the Q&A box related to chemical constituents or anything else that you want to just answer in the minute or two that we have left before we adjourn at 1:30.
Yeah, so I think again I'd emphasize on the chemicals that we are going to find if there are discrepancies in the metabolites of chemicals, we are very likely to find it, and that's something that is we're going after that with a lot of rigor and putting a lot of resources toward that in our study. Don't really.
Thank you so much, everybody. Thank you, everybody, for the thoughtful and insightful questions. As I mentioned, we will be preparing a summary, which we will list the questions, the responses, and if there's anything that we weren't able to answer today, we will try to supplement the answers in that summary. So hope to see some of you at the in-person meeting on Thursday. Dr. Jarrett, did you want to say something before we
I just noticed one other question. Can the core group that's on the Zoom please answer if they have ever been a part of a study of this magnitude and complexity before? And the answer is yes, we have been. Several of us.
Thank you. Okay, with that, we'll adjourn this meeting. Have a great rest of your day. And take care.